colorectal cancer screening saves lives. Together, we can reach colorectal cancer screening rates of 80% in every community. You can increase screening rates in your practice with the new NCCRT Steps Guide. The new guide contains expert-endorsed strategies, screening options, templates, tools, and more. Major guidelines recommend starting colorectal cancer screening at age 45. Timely screening is more important than ever. The Steps Guide is your one-stop shop for strategies to increase colorectal cancer screening in your practice. Get started now at nccrt.org/Steps Guide.
Hello and welcome. Good afternoon and good morning to all of you. We're so lucky and happy to have you with us today. My name is Laura Makaroff. I'm Senior Vice President of Prevention and Early Detection at the American Cancer Society. I'm a family physician by training, and I'm also really pleased to be a steering committee member of the National Colorectal Cancer Roundtable. Thanks again for joining us today. We've had a lot of interest in this topic and really appreciate that you've taken time to join us today to hear more about this revised Steps Guide for increasing colorectal cancer screening in primary care. So today we're excited to introduce you to this newly updated Steps for Increasing Colorectal Cancer Screening Rates, a manual for primary care practices. The original Steps Guide was released back in 2014. It's kind of remarkable to think that it's been that long, but it has been. And that guide was really a sentinel resource in our first NCCRT campaign to reach 80% screening rates, which we called 80% by 2018. And this guide continues to be a really important resource in our current campaign, 80% in every community. The Steps Guide's been credited with increasing screening across the country in lots of different kinds of health systems, including community health centers and other federally qualified health centers. But we know that a lot of the landscape of colorectal cancer screening has changed in the past 8 years, and certainly our healthcare delivery system and the way that different priorities and COVID and all kinds of things have impacted on the landscape. So we're excited about this update. In community health centers, colorectal cancer screening has increased by 10 percentage points since HRSA, the Health Resources and Services Administration, began tracking colorectal cancer screening as part of the UDS measure set in 2012. So you see here a map of all of the various state-level screening rates across the country for community health centers. So health centers have been making tremendous progress in championing their efforts to increase screening in their communities, but really there still is enormous potential and a need to continue to help people get their screening tests done. Similarly, we are seeing exciting progress in colorectal cancer screening with the behavioral risk factor surveillance system and the colorectal cancer screening rates measured through that data set. We've seen an overall 5 percentage point increase in just the last 8 years. But again, lots of work still to do to make sure that we reach 80% or higher in every community across the nation. So the purpose of today's webinar, the guide itself is not quite ready for release. We're very close, but we're expecting to publish the guide in early August. Today, we want to share with you a preview of what you will find in the 2022 update. We'll introduce you to the 4 steps for increasing colorectal cancer screening in your practice, in your setting. We'll share an overview of the contents and steps to implementation and provide a snapshot of 2 case studies and the strategies that they took to transform their colorectal cancer screening in their practices. We have a great panel of presenters today. First, you'll hear from Michelle Tropper, who's the Director of Clinical Programs at HealthEfficient and the lead author of our 2022 update. Thank you again, Michelle, for all of your efforts to get this update done. You'll also hear from Dr. Keith Winfrey, who's the Chief Medical Officer at New Orleans East Louisiana Community Health Center and a NCCRT steering committee member along with myself. And also Dr. Frank Colangelo, Chief Quality Officer at Premier Medical Associates, who also is on our NCCRT steering committee. Thank you both for all of your efforts and your practices, what you do for the NCCRT, and for sharing your successful strategies with us today. Before we get started, I have a few housekeeping items. Number 1, we are recording the webinar today, so the replay and speaker slides will be shared with all of you. Please feel free to share with your colleagues that were not able to join us today. We'll also post the recording of the webinar on the NCCRT website, so it'll be available there for you. Also, we are expecting a large number of participants, so everybody is muted on today's webinar, but we want to still make sure you get what you need out of the webinar today. So please ask your questions by submitting them through the webinar Q&A function. We will have time for questions at the end after the presentations, and we'll answer as many questions as we can. You can also email us on any specific questions after the webinar. We're always happy to engage that way as well. Finally, we always are trying to improve our webinars and our efforts here. So we're asking for your help in evaluating how helpful you found this webinar. So you'll be receiving an email with a survey link later this afternoon. We'd love for you to take a few minutes to provide your feedback. We take this advice very seriously, and we really are always looking for ways to improve. Before we turn it over to our speakers, I have a big thank you to make to the many, many contributors who generously offered their time and expertise to the development of this updated second edition. Really too many contributors to name each one, but you see the long list here, and we are really immensely grateful for your ongoing dedication and commitment that's made this work possible. So with that, I'm really pleased to turn this over to Michelle, who will walk us through the newly updated guide.
Okay. Thank you very much, Laura, and good afternoon, everyone. I'm Michelle Tropper. As Laura mentioned, I'm the Director of Clinical Programs at HealthEfficient. We are a not-for-profit organization, a health center controlled network. We are funded by the Health Resources Service Administration, HRSA, to work with our community health center members of our network and assist with their health information technology needs and clinical quality improvement and security. So this was a real treat to work on the second edition of the newly updated STEPS Guide for Increasing Colorectal Cancer Screening, a manual for primary care. And what you see here on your screen is the cover of the new guide. We are very excited to share with you the process that we went through to put together this second edition, and to share with you what you have to look forward to. Next slide, please. So just to give you an overview of the process we went through to assemble this guide, there was a very thorough review of the original guide and looking at what needed to be updated, what needed to change, and what we needed to add. And we did add quite a bit, and as well as updated quite a bit. The approach that we took was we had an advisory committee that was assembled by the National Colorectal Cancer Roundtable. The advisory committee provided input throughout the entire process, from the initial recommendations to what should be included, what should be discarded, what should be updated, as well as providing editorial review, comments, and additional guidance and advice. The updates that you'll see in the guide, we have included the new screening modalities. When the guide was originally published, MTSDNA, or multi-targeted stool DNA, or as you more familiarly know it as Cologuard, was not yet available. CT colonography was very, very new, and high sensitivity stool testing was just taking off. So all of those are now included with, along with information about each of the tests and intervals for them. There's an updated literature review with an annotated bibliography. So if you're a researcher or you're looking for information to include maybe in a grant application, or even just to provide background to your colleagues that you're working with for support of a particular intervention, you'll find this bibliography very helpful because we have broken it out by subject category and not. So when you're looking at the guide and going through it and you find a reference, you'll find it in the list of references based on where it appears in the guide, but then you will also see in the annotated bibliography the topics that those references are related to. We have included the updated screening guidelines, which were updated in the process of updating the guide. So the new guidelines that were issued in May of 2021 are included in the guide. There are new appendices and tools that are based on conversations that we had with numerous practices throughout the country. There is a new colonoscopy needs calculator that was developed by the Roundtable. And the new guide is geared towards all primary care audiences. The original guide was specifically for federally qualified health centers. They're still called out and featured in this guide, but we've also provided information about other primary care audiences, and also took into account whether practices are rural or urban or suburban. That was one of the needs that was identified in the interviews that we conducted prior to putting together the updated guide. We conducted 10, well, we actually conducted more than 10 interviews, but we have featured 10 interviews and case studies in the updated guide. And each of these interviews, case studies, has different tools that are associated with the best practices that were implemented by the group. So in some cases, they're best practices that were developed by the group. In other instances, these case studies describe effective implementation of an evidence-based intervention and what worked at a particular practice. And finally, there's also an abnormal stool test best practices brief that we compiled for the Roundtable that focuses specifically on efforts to follow up on abnormal stool tests to complete the screening process. Next slide, please. So one of the first things we did in putting together this guide was we asked users of the guide to share with us how it's been used. And we anticipate that these uses will continue to be ones that the new guide that individuals using the new guide will experience, and we'll probably identify some additional uses with the new guide. But comments that we received from those interviewed, it's a credible reference to brainstorm ideas. People use it to identify evidence-based recommendations to increase screening rates. And while this isn't an exhaustive compendium of evidence-based recommendation, it's a really good set of them. And there are plenty of links to find additional evidence-based recommendations in databases. So it's not to be intended as the end-all be-all of evidence-based recommendations, but a really good starting place for primary care practices to start with, to identify those evidence-based recommendations, and then to identify other sources and resources to help find those evidence-based recommendations. Also, to identify ways to pay for colorectal cancer screening, different experiences of groups who have found innovative ways to pay for colorectal cancer screening in their communities, the FluFit program, an opportunistic screening program that takes advantage of implementing a fecal immunochemical test for colorectal cancer screening, along with promoting flu tests in flu season, identifying tested messages for promoting colorectal cancer screening, generating ideas for tracking follow-up and provider recall, and also a guideline resource. The bibliography and reference list is quite extensive, and I think that with the new guide, this is going to be one of the favorite tools within the STEPS guide. Next slide, please. So you could see even our graphic here. I love this graphic of the STEPS guide for 1, 2, 3, and 4. You can see it going up like a staircase, and each of these is a step in the process, along with the arrows to demonstrate the importance of feedback and closing the loop in the process. So step 1, and actually for all these steps, you're going to see the steps are the same if you're familiar with the older STEPS guide. So we haven't changed the numbers of the steps. We just updated and maybe abbreviated a little bit the name of the step, but we also included some new information and tools. So step 1, make a plan. We've now included steps for data validation and readiness assessment, as well as clinical decision support for quality improvement. So that's step number 1 addition. In step number 2, identify a team. We've included steps for an internal cross-functional team and also added steps for reviewing workflows and identifying opportunities. In step 3, screen patients, we added a section on documentation of results in the EHR. And in coordinating care, we included a process for follow-up with patients for any abnormal results. This is really important because that was something that was lacking in the original guide. The appendix, or not, it's actually a separate standalone follow-up for abnormal stool tests. That particular reference, as well as other references within the full steps guide, now include those processes for follow-up of any abnormal results. Next slide, please. Some of the highlights of our new appendices: we have the new NCCRT colonoscopy needs calculator, and the link for that calculator is shown on this slide. It's within the guide as well. So those who use the older calculator, you'll really enjoy this one because it's a step-by-step process and very easy to use. There are readiness assessment tools for practices. We use one at HealthEfficient called the Colorectal Clinical Decision Support for Quality Improvement. And we've included an example of how we use that. That's based on work that was published by AHRQ and TMI Consulting. There's also the West Virginia Partnership to Increase Colorectal Cancer Screening, the West Virginia PICCS Partner Clinic Readiness Assessment Toolkit, and we also included the New York State Colorectal Cancer Clinic Readiness Assessment Tool. There's the FIT, FOBT sample workflow process, as well as updated EHR workflow documentation screenshots. Next slide, please. So the 10 case studies and appendices that are included are from the health centers that are listed on this slide. You can see these are a wide range of primary care practice case studies, and you'll hear from 2 of them after me this afternoon. So Allegheny Health Network Premier Medical Associates and Dr. Frank Colangelo, who's also joining us this afternoon. He was one of the individuals we interviewed at his practice. Coal Country Community Health Center out in South Dakota, as well as East Boston Neighborhood Health Center in Massachusetts, Family Medical and Counseling Services in Washington, D.C., Mercy Health System in Missouri, Noella Community Health Center with Dr. Keith Winfrey, who is also joining us this afternoon, North Hudson Community Health Center in New Jersey, Sanford Health, also in South Dakota, Tiburcio Vasquez Health Center in California, and Zufuol Community Health Center in New Jersey. Next slide. You'll see all these different icons in here that relate to a different type of innovation or tool that was shared in each of the case studies. That should help you identify different tools and strategies you might want to utilize. And you could see them listed here. I'm not going to go through each one of them, but these are designed to make it fairly easy for you to locate the information you might be looking for and type of intervention you would want to implement in your practice. Next slide, please. With regards to the importance of follow-up of abnormal results, stool tests only save lives if they are followed up appropriately when abnormal. And we're real excited that CMS has recognized that and has made that part of the screening process officially. Thank you to all the advocates who worked really hard to make sure that that happened. And I know we were putting an update into the final version of this STEPS guide, so it is in there for those that need to reference it. Colonoscopy within 1 year of an abnormal result rarely exceeds 50%. And practices need to develop workflows to implement steps to close the loop on the screening process and verify that the test was completed as ordered. So we really stress this throughout the guide and in our supplement. Next slide, please. It's really important to clearly communicate results and next steps to patients. And the U.S. Preventive Services Task Force clearly states in its colorectal cancer screening guidelines that follow-up of positive screening test results requires colonoscopy regardless of the screening test used. So these are all really important points that we've provided really good evidence and background information to support when you need to use that. Next slide. So this just gives you a few examples of some of the best practices for follow-up of abnormal results that are included in the guide. I've highlighted some key ones here on this slide and the next one. So you can see using registries to track patients with abnormal FIT results, standardized and scripted approach to follow-up, patient navigators, ensuring quality screening for stool-based screening program. Next slide. A mailed FIT test outreach, tracking return rates and follow-up, delaying colonoscopy after an abnormal stool test can have major consequences, including increased risk for cancer diagnosis, late-stage cancer at diagnosis, death from colorectal cancer. That's an important point that we stress for why the follow-up from an abnormal result is so important. And then establishing a medical neighborhood. Next slide, please. So I know we're going to be answering questions a little bit later, and I'm going to pass it back to Laura for some additional information and our next speakers.
Great. Thank you so much, Michelle. We're really so grateful for your vision and the dedication that you've shown to make this update possible. So thanks so much for walking us through the kind of layout and organization. And I think everyone's going to be really excited to have their release in hand in just a couple weeks. So now I'm pleased to turn it over to two of our case study contributors. We'll start with Dr. Winfrey and then follow with Dr. Colangelo. Dr. Winfrey?
Yes, good morning and welcome everyone. I'm so grateful and thankful for the opportunity to speak today and really speak on behalf of the STEPS Guide. A little bit about our health center. Again, we're set in New Orleans. We are in New Orleans East, and we have a little over 4,000 unique patients that we care for. 95% of those patients are at or below 200% of the federal poverty guideline, and 2/3 of our population is best served in a language other than English. And about 27% of our patients are uninsured. And so for us, when we want to approach colorectal cancer screening and improve our rates, for those who are familiar with our story, you know that the STEPS Guide was very instrumental in our approach. If we can go to the next slide, what we see is that one of the great things about colorectal cancer screening is the many options that are available for screening. But one of the challenges that exists is the number of options that are available. And so when there's many options, providers tend to go in different directions as far as what test they recommend and how they recommend it. And some of the staff do the same. So for us, using the STEPS Guide really helped us to weigh out the pros and the cons of various screening options and then choose one that we saw best fit our patients. So as you saw in the first slide, over 2/3 of our patients speak a language other than English, or their language best served other than English. And a significant number of those patients also are uninsured or have Medicaid. So for us, it was very important that we could replicate the communication and education, as well as have an opportunity to enhance screening, provide screening in front of our patients. So for us, the FIT strategy was a great opportunity. It was and improve our screening rate. There have been and still are challenges to the stool-based approach, but overall it's proven very successful for us in improving our rates and as a sustainable screening tool or strategy when we have a large staff turnover or during the pandemic. So we have employed the mailed FIT strategy. Patient navigators have been very vital, important to our process, and ensuring that all staff are trained on how to educate and distribute FIT kits was also a key for our organization. Major challenge has been FIT return rates. And so we've always looked at how we can go about improving that. Sometimes it takes 2 or 3 fit tests to get patients to bring one back. But again, overall, this screening method and this evidence-based approach has found itself to be very successful for us because it was cheap, it's easy to perform, and we was able to get in a larger number of patients in our practice. Our screening rates, again, have remained pretty sustainable over the years, even through the pandemic. And I think that's in large part because of the screening approach that we chose. Next slide. So when we look at the STEPS guide, focusing on step 1, make a plan. Again, that's for us was one step that I wanted to highlight this morning, mainly because that's where it all begins. Our organization, when we first got serious about improving our screening rates, we were ready for change. We just needed a clear plan, and we needed a plan that everyone can get behind. And so looking at the various evidence-based options, weighing them out in terms of our community, our patients, and the pros and cons really is what helped us be more successful and not waste time piloting or trying out different approaches. And so that's one of the things I loved about the STEPS guide is that it already has various case studies. It already has looked at options that primary care providers can use for improving screening, pros and cons to each of those steps. So you don't have to waste time trying to decide which one worked best for you or if this will work. It's already spelled out for you. You just have to have your team committed to incorporating those steps and then following it through. The next key for us was calculating the need for colonoscopy. So we knew that although we were going with a stool-based approach, that the end game is always to get a patient a colonoscopy. We knew that because of our population, the number of patients that we could get in for a colonoscopy would be challenging per year. And so what I loved about the ability to calculate the need for colonoscopy, one, I wasn't even aware that was possible. But you can actually anticipate and calculate that need, looking at high-risk individuals in your population that may be due for screening, as well as calculating the average risk individuals and their need for colonoscopy. And so with that, when you start looking outside of your own health system as some of your partnering endoscopists, you then can come to them with an ask that's more specific. They know exactly how many patients you're asking them to assist you with in a colonoscopy. You can give them more information about your demographics. So again, it just helps with that planning process to set you up for success. And so again, when we got serious about our screening and focused on the STEPS guide, we became a lot more efficient in our workflow, and that's what's helped us be successful. So I'm truly grateful for the STEPS guide. I'm looking forward to the new edition that's coming out. And I strongly encourage health centers to take advantage of this guide and the resources within it. Again, we see across the nation, health centers are struggling to improve colorectal cancer screening rate. Instead of trying to reinvent the wheel, you have a toolkit here that has evidence-based resources, examples, as well as strategies that'll help you. So I'm excited about it, and I'm looking forward to the guide when it comes out. Next, I'd like to turn it over to Dr. Colangelo so he can share more about how his organization has benefited from the guide.
Thank you, Keith, for sharing your great success story. So I'm going to talk about myself. I'm Frank Colangelo. I'm an internist. I work at Premier Medical Associates, which is a multi-specialty group of about 100 providers in the eastern suburbs of Pittsburgh, and we are a part of the larger Allegheny Health Network, which covers all of Western Pennsylvania. And we have 7 large, busy adult primary care offices that are part of the Premier footprint. And the demographics of our practice are listed in the under the statistics part of this slide. It's kind of interesting. The practice on the far east side of Premier probably has about 1% Black and African American patients. The one on the far west side is closer to center Pittsburgh, has about 25% Black and African American patients. And yet every single one of our adult primary care offices has hit an 80% screening rate. And many of the lessons that we learned from the original STEPS guide were employed to try to reach those goals. So if you go to the next slide, please. Oh, that's one too many. So, when we started this journey a decade ago also at Premier and worked with the National Colorectal Cancer Roundtable resources. And, at that time I would talk to many of my partners and I would hear, all I order are colonoscopies. Colonoscopies are the gold standard. I'm not doing any other testing from that. And we offered to physicians and to all providers the need to offer patients change. And Dr. Wender, who works with the roundtable for so long, always said you can drive good screening rates if you offer colonoscopy only. You will not obtain great screening rates unless you offer patients choice. And as time goes on and there are more options available for screening, we've made these all be part of the menu of offerings to our patients. One of the things that we learned within our practice that's highlighted in our profile is we started to transparently report how physicians' individual panels were doing in terms of reaching an 80% screening rate. So when we started publishing this among all the doctors in the practice, those who were below the 80% mark became upset, that claiming that we were bothering their self-esteem, but we stuck with it. And now everyone across the practice has hit this 80% screening mark, and I give that some credit. We proactively outreach to patients who are each reaching a screening age. And I have an example of something on the next slide that we'll have to update a little bit. We leverage automated robocall reminders. If we're going to have a mailed fit campaign several weeks before that, we will send text messages or voicemail messages to patients saying, you're due for screening. It's, did you know people starting at the age of 45 need to be screened? So we do that. And we think usually when we have our mailed fit campaigns, we'll get over 50% return rates on them, which is very good. And I have to give some credit to the automated reminders that happen. And then one of the most important things, I can remember our first year into this effort, I looked back and realized that only 55 or 57% of our patients who had had an abnormal fit test in the previous year had completed a follow-up colonoscopy to complete their screening. And, we have worked out some processes that I'm going to describe in the next slide that has greatly improved our follow-up rate for abnormal testing. So I didn't realize the one typo. It took us from 2012 to 2016 to get from 57.5% to 80% across the practice, but we have stayed above 80%, even with the pandemic years of 20 and 21, we have stayed above an 80% screening rate. So next slide, please. So I want to spotlight step number 3 that Michelle showed us: get patient screened. We repeatedly told our physicians the number one reason why patients get screened is that they are reminded by a provider or a member of the provider care team. One of the most influential factors on patient screening behavior. The converse is also true. Many people who haven't been screened say it's because their practices that they attend to have never reminded them about it. So we've made this part of the entire Premier process. Our medical assistants will talk to patients about it. The practice assistants, when a patient's registering, will ask about colon cancer screening. Each of our providers do. And then the other thing that happened is we have this organized system that tracks screening tests. So about 1/6 of our patients decide to be screened with FITs on an annual basis. And a problem about that approach is 366 days after they had their last test done, they are no longer considered current with screening. So on the 11-month anniversary of last year's FIT test, our quality team mails out in bulk the tests to patients so that they have a month to get them back, and we never fall out of screening for that group of patients. But on top of that, every Monday, and I just received it about an hour ago, I get a report from our internal laboratory of all patients who had a positive FIT test. And we have a process to make sure, number one, was the patient notified of the positive result. Number two was an order for a follow-up colonoscopy to complete the screening paradigm received. And then number three, if the patients are delaying, we have a registered letter that gets sent out to the patients after a month, reminding them of the importance to have the testing done. So on the lower right part is sort of the things that we track inside the registry. And then this process of developing the steps guides has been going on for a couple of years. And this robocall that we sent on the 50th birthday, well, we've changed that. It's now the 45th birthday. So with the guidelines changing last May, I forgot that slide was in there from when we had started working on the screening or the steps guide 2 years ago, but we've now changed that to the 45th birthday. So patients receive a robo message a month before their 45th birthday. And then if they have not been screened, we send them out the mailed fit kit, letting them know that there's a way that they can be screened in a simple fashion at home. So within the last year, we have increased our screening rate in our 45 to 50 age group from about 33% to 55% just by following this. And we're going to keep trying to get that age group up into the 80% range is our goal over time. So I think that's the think that's the last of my slides and things. And, just wanted to say, give a shout out for the STEPS guide again. The work that we do with practice across the country, the shared learning that is inside the STEPS guide is key and influential. Keith mentioned this before. We always say when we're using something like this, we're doing our R&D. We're not researching and developing. We are robbing and duplicating the successful ideas that other organizations have shared with us. This guide is going to be filled with things that I'm sure you will be able to implement either within your qualified health center or in a primary care practice, whether you're urban, whether you're rural. I think it's all going to be covered in here, and I encourage you to dive into it when it becomes available in the next couple of weeks, because I think it'll be able to help you with your efforts for increasing colon cancer screening rates. So thank you. Now I'm going to turn it back over to Laura for a minute.
Great. Thanks so much, Frank, and thanks, Keith. That was really just so fantastic. There's nothing like just hearing from each other, like you said, and robbing and duplicating. I love that. That just nothing better than hearing the nuts and bolts of what actually can work and has worked, and then ways that you might be able to adapt that to your setting. So now we have plenty of time, and we did this on purpose. We wanted to have plenty of time for some discussion and Q&A. So if you have a question, please submit it through the Q&A box that's there on the bottom of your Zoom screen. We'll take them one by one. I'll invite Frank and Keith and Michelle to join me back here. I'm going to look over at my other screen to get the first question. So the first question is this: what are some examples of recommended strategies for rural clinics? And are there any specific case studies we should look to as examples for rural practice? So maybe Michelle, you want to take that first?
Sure, happy to do that. So we actually had two clinics, and I apologize, they're in North Dakota, not South Dakota. We had Coal Country as well as Sanford Health, and they're both featured case studies. Some examples of the kinds of things that they did to help increase screening rates in their rural practices. They used the mailed kit approach to eliminate transportation barriers. They also arranged for housing sometimes, because these folks travel really large distances to get to their clinics, sometimes over 100 miles just to get to an office visit. So they've made arrangements with local hotels or other places to house the patients when they come in for their screening. They also do outreach telephone calls to assess readiness for intervention. I thought that was pretty interesting. It's one thing to bring someone in and counsel them and provide them with information about the need and importance for colon cancer screening. But then if you have assessed their readiness to actually go through and do the test, you'll save a lot of time and cut back on some of those barriers, especially that big transportation barrier was really huge. There's also the Saturday colonoscopy screening days that have been featured by the Roundtable and other forums. And that was practice that was found to be effective in some of the rural clinics, as well as encouraging patients to schedule colonoscopy using the patient portal. So combination of different strategies, really putting the patient at the center for patient-centered care and enabling them to get screened when they're ready, and also to take charge of addressing some of those big barriers.
Great, thanks so much, Michelle. I don't know, Frank or Keith, do you have anything to add on that? Any experience you have in reaching out to settings that may be less urban in your areas?
I could take that, Laura. I know with some of the work I've done with practices across the country, I'm in Intermountain that is over 7 or 8 states now, and Geisinger in the Guthrie Clinic in northeastern Pennsylvania, which is very rural. They definitely leverage the mailed fit as a way of trying to reach their patients for screening. Now, then the issue they encounter, what happens when someone is positive and they're 4 hours away from their closest site to receive a colonoscopy. They're working on that, but they have definitely leveraged the mailed fit strategy to help to improve their overall screening rates for those populations.
Yeah, that's helpful. Anything that you'd want to add, Keith? It's okay if you don't. I just want to miss you if you did.
No, nothing extra. I think Michelle and Frank hit the nail on the head. I think leveraging the mail fit, and I think then maybe making arrangements for individuals who need the colonoscopy to be able to stay maybe in hotels closer.
That's great. Yeah, definitely. Mail fit can be super helpful. When the guide is released, just for all the participants out there, there's that list of icons that Michelle went through. So the case studies will be the ones specific about rural settings, have a little rural icon. So you'll be able to find those quickly when you see the final version of the STEPS guide. I have another question. The next question is, how can my organization help get the STEPS guide into the hands of our physicians? So I'm going to say one quick thing about some things that we will be sending out from the NCCRT. And then Frank and Keith, maybe you can mention just how you kind of handled or tackled both the learning for your clinician colleagues as well as the unlearning, which sometimes I think is maybe the harder part of our clinical lives is learning something new or unlearning something that maybe has evolved or changed because of the science. So let me just say one quick thing and then I'll hand it to you guys. So all of you, the NCCRT members and our member organizations play such a crucial role in helping us promote and disseminate these valuable resources. So we will be sending out after this webinar to all of you, both the STEPS guide itself when it's released, as well as some promotional materials to include that video that we showed at the beginning, as well as some information about what the STEPS guide is that you can use in your settings across your practices and your newsletters, or just disseminate it and forward the email, however you all do it, to help people take a look at it and just, kind of get familiar with what's in there. And maybe it'll just inspire someone to become one of your champions, and that can make a big difference too. So those are a few ideas from our standpoint from the NCCRT. Frank and Keith, do you want to just talk about how you handled that sort of learning process with your clinical care teams?
Sure. I know for us, our provider meetings were very key in helping to raise the awareness of the need. So we had overall screening rates for the population, and then we had individual screening rates by provider. So they kind of, put them in the forefront of being responsible for their own individual screening rates. And then we use it as an opportunity to explain why the clinic as a whole is going to be adopting a new approach for screening for our population. Again, we let the providers know that they're still responsible for knowing what's unique about their patients. If there's any high-risk individuals or anyone with family history, then they may have to use a different strategy or approach. But for our average risk individuals, we have a straightforward policy that we were rolling out that included standing orders for mail fits and for fit testing for those who are appropriate. So the education piece, we use our provider meetings as opportunities to go through some of the new guidelines and the new recommendations and some of the approaches that we're going to use. On more of a larger level, our primary care association would have in their annual meetings or regular meetings, opportunities set aside for us to discuss screening opportunities such as this. And so we use this as an opportunity to kind of make them aware of changes to guidelines or new tools or resources that are available. So I would say provider meetings locally, and then the primary care association for community health centers, and then other professional societies for other primary care providers.
Helpful. That's great. Frank, anything to add to that? Or
I'll just say the same. I mean, we've been at this for a decade, and it's still, whether it's a quarterly meeting, of all the providers, a monthly meeting. I mean, it's always on the agenda. There's always something new. Okay, this is your follow-up rate after positive fit. Now they've reduced the screening age to 45. If the latest one that we tackled in the last year was there were a disparity in screening rates between our races, and pointing out to the providers that there was one and that they needed to work on closing that. We successfully did this. There's always a new topic. And when the USPSTF updated their guidelines last May, I mean, me as the chief quality officer, the next morning, there was an email to everyone saying, in case you didn't see this, and in case patients start asking, this is what, the screening rate was officially now 45. So just being in charge and on top of people and letting them know that the current science regarding the topic is beneficial. So.
Yeah, helpful. Thanks so much. So those are all helpful. Again, and this webinar will be recorded. So it's another thing you're welcome to use and share pieces of this or all of it with your provider teams and your settings too. I have another question, a quick question and then a longer question. My quick question that came in is about where is the colonoscopy needs calculator located? So Emily or Caitlin is going to put that link into the chat. It's on the NCCRT website. So we'll put that link into the chat so you can get directly to that colonoscopy needs calculator. It's really cool and really helpful because so often I think we as clinicians, especially when we're transitioning and wanting to use more fit, we want to make sure that we have the appropriate follow-up in place for those who either need a colonoscopy to start because they're high risk, like Keith mentioned, or if they have an abnormal or positive fit, we want to make sure. And this calculator is so helpful to get a sense of like how many colonoscopies you think you might need in a given year, and then how to go to your specialty partners and colonoscopy providers to help come together and figure that out. And usually it's not a lot for, per specialty partner. It's usually not a lot, and usually people are pretty open to helping out, even for those patients who may not have insurance or may have be underinsured. So that's the quick question. The longer question is this, for Keith and Frank, and Michelle, you may have some ideas from the HCCN perspective. There was a question about how does one create a provider dashboard? So maybe you can just speak to like what your dashboard process is and how you've each done that. Keith, do you want to start, and then we can move along the panel.
Sure. So our QI director was one who was very instrumental at being creative at how she presented the data. Of course, our EHR presented some cursory data, but it was very limited. And so she was able to take that information, actually go into her own Excel spreadsheet and kind of change the data around or put it together in a way that kind of resonated or popped with the providers. So one was our EHR, two was just the creativity of our QI director to see what would make sense for the provider, what would kind of get their attention and raise their level of concern about being more proactive in getting screening done. We also had a data platform, data analytic platform that sat on top of our EHR, one called Azara, and that information was able to provide some additional tools and screening and graphs and just different ways of showing the data that allowed, again, the providers to really understand the disparities that Frank was mentioning. We also looked at disparities from ages, from races, or ethnicities within our organization, by provider, as an organization as a whole. But I think in a large part had to do with our QI director and just how creative she was at using the data to speak to the providers.
Very similar story to Keith's also. I mean, our registry sits on top of the EHR. We're able to export it to Excel and then create a visualization for the providers. And something I'll recommend, we put, there was a bar graph with everyone's performance. When we put the 80% line across the bar graph is when the people who were below that line went nuts. I mean, they were upset that they were being pointed out. But that putting a goal and making it very visual, I think helps your efforts. Also, it encourages people to try to increase their screening rates.
Definitely.
Yeah, and I'll just add on, the databases, for provider databases, there are often ways that you can extract data from your EHR using other tools. So some that we use in our Health Center Control Network, we use the Tableau tool for displaying the data, and also we use different tools to extract the data. So we have a population health platform that many of our members are using called Relevant. There are other tools like Azara or Bridge IT. Those are other ones that you can use to extract data from your electronic health record, and then you could bring that in or import it. Relevant has a real nice visualization tool, so you might not need to use another tool like Tableau. But these are all different types of tools that are out there that can be integrated or layered on with the EHR to help create these different types of displays without having to have a separate database necessarily. All the data could be kept in your EHR, and then you extract what you want to display and share with your providers, with your board members, funders, et cetera.
Helpful. Thank you all. Yeah, there's nothing like having your own data to see like what when I get data back as a clinician, sometimes I'm upset too. And then I have to look at it and say, well, this is to help me understand where my gaps are. Because I may think that and maybe I am doing a good job making a recommendation, but if my patients aren't completing their fit test and sending it back, or are facing barriers as they're scheduling their screening colonoscopy or their follow-up colonoscopy, then we need to fix, their system things, and I can, utilize my team and help patients actually complete their screening. So nothing like data to help motivate us. We're all high performers. I know all of us clinicians. We want to do a good job. We just need the right systems to help us do a good job. Yeah.
And Laura, I'll mention, I hear my partners will say, well, I recommend it to every single patient that I see. Well, we don't see every single patient every year too. So that's population health management. As far as this, we need the registries to know those who require outreach that aren't showing up in front of you in the office. So,
Yeah, absolutely. Absolutely. That's so helpful. I have another question for you, Frank, about the robocalls. Do you outsource the robocalls for the fit follow-up? And then are you using your patient portal for some of that as well? Can you speak to that a little bit?
Yeah, we've definitely leveraged the portal for that. And that's all patients that have had mailed fits that haven't returned them yet. We'll nudge them saying, you got that. The robocall, it's our platform that we use to remind patients that they have an appointment in 2 days. We get a certain number of credits for having phone outreach with them. So myself and one of the quality teams are good at, because I think it's like 140 character messages that we can create, and it gets sent out. So we do that internally. Just it's part of our package of patient reminder calls that they have an upcoming appointment. So, yeah.
Cool. That's great. Helpful. I have another question about follow-up colonoscopy. So the question is, what is the time frame for Medicare to make a decision on cost sharing for follow-up colonoscopy for an abnormal stool-based test? This has been a barrier and one main reason why providers are recommending colonoscopy first. Totally been a big barrier. So if you haven't heard, there is good news that CMS did release a proposed rule, so proposal to eliminate cost sharing for follow-up colonoscopies, meaning that a FIT test plus a follow-up colonoscopy is all considered the screening process. And that should be, if it's finalized, which we hope it would be in effect for Medicare starting in 2023. Of course, the commercial payers will follow suit after Medicare does something. Usually, commercial payers can choose to do what they want, by the way. I don't know if we have any payer friends on, but it's not, usually they'll follow CMS, but the commercial payers can decide to do their policies different on the follow-up colonoscopy. But that's what we are expecting for the proposed rule about CMS covering follow-up colonoscopy. So it's very good news. Will help break down a big barrier. So keep your eyes on that. I have another question. Let's see what this question is. I'm trying to read live. So give me just a second. The question is about risk and identifying patients who are high risk. This is a great question. The question is, when or where is a good place to screen patients for risk status, and who's normally responsible for this risk assessment? I think that falls into family history and otherwise identifying patients who may be high risk. So can you all speak to that? Let's start with Frank this time, and then we'll go to you, Keith, and Michelle, you may have things to add on the way that Health IT can help with this part of things too.
Yeah, I think we've leveraged the primary care provider to as part of that family history to elucidate that, the history of polyps, the history of colon cancers, and designating that as a high-risk patient who the only way that they can be screened is with a direct visualization with a colonoscopy. So we rely on our providers to do that. So.
Yeah.
And I agree with Frank, same thing. One of the things that's unique about Louisiana is that we have large pockets within the state that has very high family history of colorectal cancer, much higher than the actual national average. And so it's very important for our providers to be asking about family history of colorectal cancer, but also about polyps. That's one of the things that we have to remind our providers as well, is that if you have family members who've had polyps under 50, then that could also put you at risk, and your patients need to know that as well. So not just cancer, but also presence of polyps. But providers are the ones who are asking those questions.
Yeah, great.
And then from an HIT perspective, what I'll add is when you're documenting this information in the EHR, please document it in structured fields. Because if you want to use this data for anything other than a conversation with a patient, if you want to use it for population health management, it needs to be in a structured data field if you're going to be able to pull it out on the other end and pull a report of your patients. If it's buried in a note somewhere, it's unlikely that you'll be able to utilize it beyond the one-on-one visit with the patient.
Really great point. The structured data is so key. That's such an important point. Let me just also remind everyone, it's a couple years old, but still really helpful. The Colorectal Cancer Roundtable does have a risk assessment and screening toolkit that really walks walks you through like how to get a good family history, how to do a good risk assessment and do that. So it's another good tool that you can use in your settings. And that would be a great topic for a provider meeting, if I don't say so myself. Those are things that are important and can sometimes kind of fall off the list amidst a busy visit with your patients. But getting that back on everyone's radar and how important it is to identify patients who may be at higher risk and should be screened earlier is so key and really important, especially as we're seeing all of this early age onset colorectal cancer. So we want to make sure we're identifying people who are higher risk either before the screening age of 45 or because they need a direct visualization test. So just a reminder on all of that.
And Laura, if I can add, sometimes the team can set up to where maybe the medical assistant or whoever's doing the triage can include that in the questions that they're asking as well, so that burden doesn't always have to fall on the provider. If you have, certain intake staff that are capturing regular history information, having them include a template or have them include questions on colorectal cancer screening will be helpful.
Yeah, that's great. And that can be part of standing orders or your kind of office policies that you develop. Is such a great, important point is that the team and helping utilize the team for that kind of thing can make a big difference and really help with your kind of process overall. We're getting close to time. I'm going to ask one more scientific question, but a really important question. Can you maybe we'll start with you, Frank. Just discuss your reasons for choosing FIT over multi-target stool DNA or Cologuard. Any thoughts on that, or any quick review of the literature?
Quickly, we said we started in 2012 before the Cologuard was available. So our patients who have been doing FITs every year have been used to doing FITs every year. About 2 or 3% of our patients do the multi-target stool DNA test, so it's not a zero. But we're a little bit concerned about the higher false positive rate on the Cologuard test and the increased cost. $22 for a FIT, $600 for the multi-target stool DNA test. So, but it's more just out of habit that patients were used to doing FITs before the Cologuard test became available. So
helpful. Anything you'd add on that, Keith, for your setting, community health center setting?
Yeah, I'll say similar to Frank. I think in the past it was cheap to do a FIT test. The data shows effective as far as specificity goes. And so it's easy to kind of get it in the hands of our patients. Now, of course, this year we're looking to be more creative and trying to get the multi-target stool DNA test, give our patients access to those, particularly our uninsured patients. And so we're finding some success with it, but it is a different workflow. And so it's not as straightforward and as easy as doing the FIT, but we do find it has been successful as well. So I think whichever one they choose to go with, you have to look at your population and their ability to access it, and then make sure the workflow supports the steps so it can be successful.
Great. Yeah, helpful. I think another important point and such a good point to close on around the importance of choice, and that there is really good literature and what we've heard from our presenters today, that if we offer patients choice in a colorectal cancer screening test, they're more likely to complete that test. So that's another important point around FIT, multi-target stool DNA, colonoscopy, and I guess for some patients, CT colonography where that's available is also evidence-based and part of our guidelines. Quickly, I'm going to kind of wrap us up here as we are nearing the end. So again, thank you, Keith, Frank, and Michelle for your presentations today and all of your efforts to help us get this manual updated. If we didn't get to your question, we will send some questions and answers out in a follow-up email. We will email all of you the link to the new guide as soon as it's published in the next couple of weeks. We encourage you to connect with us on social media to learn more about what's happening with the National Colorectal Cancer Roundtable, our other upcoming webinars and other news. You can find us on Twitter and our website there. All of our other resources are available on the website as well. You can also find out how to apply for NCCRT membership and get involved in our task groups and other work too. So again, a huge thank you to our speakers. Thank you again for generously sharing your time and expertise with us today. We really appreciate it and appreciate the support of the CDC and their ongoing commitment and support of the roundtable as well. If you have other questions, please email us, nccrt@cancer.org. Thank you again for joining us. Hope you all have a wonderful afternoon, and we look forward to seeing you again soon.